Okay, this is the shortest presentation of them all. So what we're going to be talking about are protocols, general considerations for us, and X-ray tube housing, SID, collimation, filtration grids, SSD, and then the fluoro stuff. There's frankly a lot of numbers in here, and it's the kind of stuff that we just need to memorize. You're guaranteed to probably get at least 5 board questions off of this material alone. Because what we've had so far has been context. This is now telling us what we actually need to know as technologists in order to avoid those things. Basically, the equipment that we work with has been produced with a lot of considerations in place to make sure that it operates safely to protect both us and the patients and the general public. And the exam rooms that we're working with are designed from the ground up in order to reduce both patient and occupational dose. In general, the control panel and the console have to be located between a suitable protective barrier. And this is generally a secondary barrier, and we'll talk about what that means in a minute. But it must indicate conditions of exposure and provide a positive indication when the X-ray tube is energized. That means it has to beep and something has to light up. Guess what? If the light is not lighting up or the beep is not beeping, it is your job to make that thing light up or to make the beep beep, or to say that we can't use this machine right now. That is your job. That is clearly within your scope of practice. But I can't tell you how many X-ray rooms I've seen that don't light up or whatever when we're making an exposure. When the exposure begins, the tone is emitted and the sound stops when the exposure terminates. That is also within our job. If the thing is doing weird stuff, like it's beeping all the time or whatever, we need to say, hey, there's something wrong with this machine. Let's get it recalibrated. Examination tables need to be strong enough to support the patient, but at the same time, they need to be of a uniform thickness and radiolucent as possible. So in general, they're made out of like carbon or carbonite or carbon fibers in order to reduce both the patient dose and scatter. Tube housing. Here's a number we need to memorize. Leakage radiation measured at 1 meter from the X-ray source should not exceed 1 milligray air per hour when the tube is operated at highest voltage at the highest current. The way this is generally measured is it's extrapolated from like a minute-long exposure or from a 10-second exposure. They extrapolate it out to an hour, so they measure leakage radiation at the tube and then extrapolate that out. But what that's saying is that there shouldn't be really any leakage whatsoever coming out of the X-ray tube itself. That's why the tube is so heavy, is how much lead is in the tube to keep the leakage down. And again, 1 milligray per hour. The SID indicator needs to be working. So I know that there's been questions like, for example, in the presidential suite, where's the laser? How do I know whether this machine is at 42 or 72 or 55 or where the hell am I shooting at from, right? The indicator needs to work appropriately, right? It does work, it's just kind of hard to see sometimes. So even though it's a simple device like a measuring tape, it has to be accurate. And the distance and centering indicators both, when we turn on the centering indicator for the collimator and we center the X-ray tube, it has to be accurate to within 2% of the distance and 1% of the SID. So that's 2% of the centering, 2% of the distance, it has to be accurate, 1% of the SID for centering, right? So if it's off by more than 1%, again, this room is not aligning appropriately. We need to have someone to come in here and realign it. The number that I would remember is 2% of those two. If you remember 2%, you're good to go. Is there questions about what I'm saying about that? Basically, I'm saying is if it's not aligning appropriately, If there's not incidence between the X-ray exposure area and what the collimator light shows you, it can't be off by more than 2%. Collimation is a good thing both for the patient and for us. It's going to significantly reduce scatter and improve the overall quality of the X-ray beam. It also reduces patient dose. Filtration. The number to memorize here is this one right here, because every machine that you're working on is going to be operating at above 70 kVp. That doesn't mean you're always shooting at above 70 kVp, but on average we're operating at or above 70 kVp. They are required to have 2.5 millimeters of aluminum equivalent. Millimeters of aluminum equivalent. And what filtration is doing is it is directly reducing patients' skin dose, their entrance skin dose. Because some of the X-rays that are being produced by the tube are soft. The filter gets rid of those soft X-rays, and all that remains are the high energy X-rays. So just the ones that would be of diagnostic value. And this is that same thing explained most again. And all of our X-ray equipment has to be appropriately filtered. One thing that is related to filtration is a half value layer, and this is related to the tube operating energy, but it's the thickness of an absorber, generally aluminum, required to decrease the intensity of the primary beam by 50% of its initial value. We calculate half value layers. There's big tables of half value layers for all sorts of different machines. It is unique to each machine, and like we talked about on exam 2, it is the best way of expressing what the X-ray machine's quality is. How high quality are the photons? That is best measured by the half value layer. So one way to think about that might be the amount of thickness of lead or what have you that the photon could pass through and keep going. That's going to be directly related to its quality. So we do measure and verify the HVL for the X-ray beam, and this is done annually by the physicist. So the thing to remember here is when it comes to X-ray beam quality, this is measured at least once a year. It's generally expressed in millimeters of aluminum, and it is the best measure of X-ray beam quality or effective energy of the X-ray beam. Reproducibility. Some of this is not in our textbook, but it is helpful to know this. Reproducibility means that there's a consistency in X-ray output. So when I do a chest X-ray at this setting, it doesn't matter if I turn it on at 6 o'clock in the morning and do it, or do it at 5 o'clock in the evening. I'm always getting about the same amount of energy coming out of the X-ray tube. And the variance for that is 5% or less, right? The exposure should not vary all that much from 5% or less. That is reproducibility of the same technique over and over and over again. Linearity has to do with altering the MA settings and making different exposures at different technique levels, right? So when the settings are changed from one MA to the neighboring MA station, the most that this can vary linearly is 10%. 10%. So reproducibility is the same exposure over and over and over again. Should not vary in its amount of radiation by more than 5%. Linearity is if I'm changing the MA station but making the same exposure at different MA stations. It should not vary by more than 10%. Grids. Grids are good, and we'll talk more about them in image evaluation. They are used to improve subject contrast. So anytime a part is more than 10 centimeters thick, we will want to employ a grid, in order to reduce scatter radiation at the image receptor. Okay? The important thing to know about grids right now is anytime we use a grid, we are increasing patient dose. Okay? Because we are reducing the amount of scatter, we're going to have to increase patient dose. That's all you need to know about grids right now. If you're using a grid, you're increasing patient dose. SSD for Mobile Radiography. SSD stands for source to skin distance. Source to skin distance. There are requirements for these. A minimum SSD that can be used is 12 inches. If you're getting closer than 12 inches, something's not right. You should not be able to get closer than 12 inches. In fact, most of our collimators and tubes are constructed in a way such to prevent that. So if you were to pull out the tape on the source to the SID measurer, it begins around 12 inches. Why? Well, it's a requirement. So in general, the distance generally used for mobile radiography is 40 inches or 48 inches for when we're doing portable chest x-rays and things. Anytime we increase the SSD, it's thought that this is going to be a more uniform distribution of the dose over the patient's skin. So increasing SSD creates a more uniform dose distribution, whether or not that's of advantage academic. Fluoro. The primary shielding for the Fluoro machine is the Fluoro intensifying tube. So that primary beam, as it exits the patient, the remnant part of it, is stopped by the intensifier. That is one of the purposes of the intensifier. The things that we can do to reduce radiation exposure in fluoroscopy is using pulsed fluoroscopy. And you can have the technologist show you that mode the next time that you're in a fluoro procedure. Ask them, what's the pulse mode look like, as well as this last image hold feature. Most of the fluoro equipment that we work with has automatic last image hold setups. Some of the older GE stuff you had to tell it to do last image hold. It is helpful, especially if we're operating a C-arm, to try to use the collimators on the fluoroscope. It will improve the image as well as reduce dose. There are some numbers to memorize here. And they are, for the fluoroscopic machines that we're using, for the stationary ones like the fluoro tables, the SSD should not be less than 15 inches. Should not be less than 15 inches for stationary, and not less than 12 inches for mobile fluoroscopes. Now, mobile fluoroscopes, you could potentially get the tube closer to the patient than 12 inches. They are not built with the same collimator setup that all of our other equipment has. So they're unique in that way. You could bring the tube too close to the patient and fry their skin. There is supposed to be an extender that comes with the tube that's supposed to be placed on there that indicates where that 12 inches is. Most people don't use that extender. I've seen one time. As a general rule of thumb, though, if you're operating a C-arm, the best thing you can do is bring the image intensifier as close as possible to the patient's skin. If I'm bringing the image intensifier as close as possible to the patient's skin, the tube is as far as possible from the patient's skin. Does that make sense? We will use timers, and they're cumulative in nature, so they have a 5-minute warning bell that sounds, and I always tell the doctor that was the 5-minute fluoro time. They'll ask you to reset it. If you go over 5 minutes, I generally document that. I document fluoro time every time I use the fluoro. But if I go over that, sometimes I fill out an incident report just to let people know we did go over the fluoro time. Every facility is a little bit different. The exposure rate limitation. So for general purpose fluoroscopy, not the high dose rate stuff, there's a maximum of 100 milligram air per minute. 100 milligram air per minute It's the max that those machines can pull off in terms of air kerma. Okay? So they cannot make exposures higher than that. And that makes sense, right? Because we've said, 100 milligray per minute. If we were to do that for 10 minutes, guess what? We just hit the threshold for cataracts, right? We just hit the threshold for cataracts. And if the 10-minute fluoro timer sounds, you just hit the threshold for cataracts. Something to know. So, how can we protect ourselves? The primary protective barrier for fluoroscopes is a 2 millimeter lead equivalent. That's within the walls or within the image intensifier. And the fluoro machine should be operated with a dead man switch. That means that your foot has to be on the thing to make it go. You can't just automatically fluoro. NCRP report number 116, memorize all these numbers now and just save yourself the hassle. I anticipate there will be test questions on every single one of these numbers. They are very, 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 very important. All right, thank y'all.